Today's topic of discussion would be your antifungals. Now, as we are looking at this diagram, we are actually looking at the site of action of major antifungals. And we see that the structure of the cell wall and cell membrane of the fungal cell can be interfered upon first, if you look at the top left, by capsofungin. Now, fungins inhibit the synthesis of beta glucan. Beta glucan is actually a part of the cell wall of the fungus. Now, working within the cell membrane will be your polyenes. Now, polyenes such as your amphotericin B, such as if you want to add over here nystatin, they will interfere with ergosterol of the membrane. And notice how ergosterol sounds like cholesterol of our own membrane. It is actually a steroid in the cell membrane of the fungus. And then we will have a group of drugs that will work on the ergosterol synthesis pathway itself with drugs such as your azoles that will inhibit the last step of ergosterol synthesis, which is they will act on the enzyme 14 alpha demethylase. Now, this particular enzyme converts lanosterol into ergosterol. And then we have got newer drugs like your terbinafine. Now, this terbinafine will inhibit squalene epoxidase. Squalene epoxidase is actually a step that is upstream from that inhibited by the azoles. So this is all about the different drugs that we will be talking about in detail in the coming slides. So let us start with the first group of antifungals that we have. Those are your amphotericin B and nystatin. Now, they are a part of a group of antifungals, what we call as the polyenes. Now, you can actually take them as magic bullets for systemic fungal infections. They are so good. Magic bullets for systemic fungal infections. Systemic fungal infections. Now, they are very powerful, and as such, we need to know them very well. And even though they are very powerful, we also need to know why we don't like using them for all this or for all the fungal infections that we have. The reason is they have got tremendous toxicities to their name. They are very toxic drugs. Right. And as we just saw in the diagram, amphotericin B, nystatin actually interact with ergosterol. Now highlight the word interact over here. I'm not saying it binds to, I'm not saying it blocks or it agonizes the ergosterol, but what I'm saying is that it just interacts with ergosterol. Now, nowhere we are saying that it blocks the synthesis of ergosterol. That will be a characteristic shared by the drugs such as your azoles and terbinafine. Now, interacting with it simply means that it binds to the ergosterol. And binding to ergosterol, it results in the formation of holes in the membrane of the fungus. And these artificial pores will cause fungicidal activity. So this, in fact, what I have described is the mechanism of action by which these polyenes work. They interact with the ergosterol in the fungal membrane to form artificial pores which will cause fungicidal activity. Now, there are already some resistant fungal strains that have been described, and most resistant involves having low ergosterol content. So the fungus having low ergosterol content will be the most resistant to these polyenes. Then amphotericin B cannot recognize where to disrupt the fungal cell membrane, and hence resistance will develop. Now, amphotericin B, coming to the activity and clinical uses, amphotericin B has the widest fungicidal spectrum. of all the antifungals. Therefore, it remains a drug of choice for any severe systematic infection that you can think of, whether it's the classic aspergillosis, which could result in necrotizing pneumonia, right? It could be systemic candidiasis caused by candida, as it affects our HIV or immunosuppressed patient, particularly the invasive form that involves the mouth and the esophagus, or whether it's an issue with your most toxic Cryptococcus meningitis, or it could be your histoplasma, maybe a diabetic developing mucormycosis, and hemorrhage of the temporal lobe, or sometimes when you are working in the gardens, you can stab yourself with the thorn of the roses and contract this disease sporothrix, which is actually a fungal disease. So basically polyenes, particularly your amphotericin B, has got a very high fungicidal spectrum. So these are some of the fungus that you need to keep in mind. Now in all these situations, amphotericin B would be the best drug to use. Now Amphotericin B is so toxic that we are going to try and use it in a combination with other drugs to allow decreasing the dose and also to achieve synergy and a decreased resistance. And to do just that, we have to use amphotericin B in a combination with flucytosine. The classic synergy is achieved with the drug flucytosine, which we will review in a second. Now, this is done particularly for HIV patients or immunosuppressive individuals for invasive candidiasis and Cryptococcus meningitis. Now, if we talk about the other drug that we have among the polyenes, and that is your nystatin. Now, nystatin is downright toxic for systemic use. So it is used only topically, right? So there is a unique use of nystatin, which is the swish and swallow technique that we have. This you will very well get it in your microbiology, the swish and swallow technique. I'll just write it down over here, swish and swallow technique. Now, the reason why we use this swish and swallow technique is because nystatin is highly toxic. Now, we use this for people who have got oral esophageal candidiasis. Basically, what we do is we ask the patient to swish and swallow the nystatin whole, knowing that nystatin will not be absorbed from the gastrointestinal tract readily. So that like this, the toxicity of nystatin would only stay within the gastrointestinal tract. So remember this for your viva also, the swish and swallow technique, particularly for nystatin. Now, coming to the pharmacokinetics of these agents, they show that it shows that they are limited by being given as a slow IV infusion, so that they will require for your patients to be in-house. Basically, your inpatients. You need to take these patients in your hospital. Now, amphotericin B has the issue of not crossing the blood-brain barrier, and then here you might think that, how am I going to use amphotericin B for Cryptococcus meningitis, even if it does not cross the blood-brain barrier? Would you believe that this is one of the few drugs we can actually administer intrathecally? That's a painful parenteral administration. So although dangerous, the idea is we can reach the CNS with amphotericin B, but it will require intrathecal administration. Now, as pharmacokinetic goes, it is a drug that has very slow clearance. And its half-life is literally counted in weeks, which if you can recall from your general principles, it will take a long time to reach steady state concentrations. That is, it will take around 4 to 5 half-lives to reach steady states in your body. And it will take just as long to clear the drug and get rid of it. Certainly, if the kidney function was impaired, then this half-life would be even greater. Now, there are two major group of side effects that concern us with the drugs like amphotericin B or your other polyene drugs, and that is your infusion-related side effects. Now, these infusion-related side effects are those of hypersensitivity. And importantly, although they can be alleviated with pre-administration with your NSAIDs or giving antihistaminics or your steroids, they are very severe, and a test dose is always advisable because of the possibility of actually going into anaphylaxis and shock. Now, the other set of side effects that we have are your dose dependent side effects. Now, the primary issue with most antibiotics, as you already know, is your nephrotoxicity. This we have discussed in all the chapters of our antibiotics, that the major side effect that the antibiotics have is your nephrotoxicity. However, this time I think you are looking at the most nephrotoxic of all the agents we have talked so far. Just remove aminoglycosides also. So it also causes nephrotoxicity, but that nephrotoxicity is nothing compared to the nephrotoxicity caused by amphotericin B. So it is so toxic that it causes toxicity to every aspect of renal function in your patient. That means it will cause glomerular damage, it will cause tubular damage, and it can even cause enough parenchymal and vascular damage in the kidney to be associated not only with renal failure, but actually it can cause normocytic normochromic anemia from the lack of erythropoietin. So supportive management of renal function is always needed when people are on slow IV infusion of amphotericin B, either with sodium fluid loading, or with trying basically to lower the dose of amphotericin B. Accordingly, thanks to synergies with the drugs like flucytosine, we are in better shape nowadays. Now, by the way, if you have read your general pharmacology, we now know that amphotericin B also exists in liposomal type of preparation in order to minimize that toxicity. A liposome being preparation that normally we love to see in the cosmetic industry. They are actually artificial bilayers of lipids, but it helps in a way in the clearance and distribution actually of the drug amphotericin B. So whatever the case might be, it may very well be the most active and the most potent of the antifungals, but these toxicities and its way of being administered are such an issue that we have to find out, or we need to go for the other set of antifungals that we have.